conference is an effort by partners to strengthen linkages, collaboration, networking and learning among NGO, government, private sector, researchers, students, multilateral and bilateral partners in malaria and child health for more effective efforts on malaria. The KeNAAM Fresh Air Conference brings together communities of stakeholders to discuss and showcase innovations in malaria intervention strategies and programmatic outcomes of projects.
Malaria is one of the top diseases which actually cause high morbidity and mortality cases in our country. And therefore, as we can remember, and we are aware that we're in the malaria field, and we can remember the MDG 6, that is where malaria is, we are working towards the reduction of the 75%. And we are also working towards the elimination of malaria, and that is according to our policy by the year 2017.
My name is Athmani Chiguzo. I'm the outgoing chair of the Kenya NGO against malaria, Kenya NGO Alliance Against Malaria. And for us, the word malaria is a misnomer because we're calling it bad air. But we want to bring in fresh air to this conference so that we bring, how best can we bring in fresh air so that we can address the malaria burden. And we're also seeing malaria-specific mortality rates between 2001 and 2010 have fallen by 33% in the whole of Africa. The three specific objectives: one is reduce the global malaria death by near zero. We're saying near zero by end of 2015. And also to reduce global malaria cases by 75% by end of 2015 from the 2000 levels. So from where we were in 2000, we would like by 2015 to have reduced by 75%. We've seen a drastic reduction in malaria in Kenya. When we started, we talked about that 4,000 children dying each year in Kenya. That is equivalent to 94 children per day in 2001. We are talking currently of 16,000 children dying each year. That is 43 per day in 2010. That means almost more than 50% reduction in child mortality.
We have about 1.7 million pregnant women a year in Tanzania, and all of those are susceptible to malaria infections. Malaria accounts for about 20% of all deaths among pregnant women.
Marlene, we've been implementing a program referred to as Commercial Malaria Communities Program, KMCP. The aim was to reduce morbidity and mortality associated with malaria in the epidemic-prone districts, Kisii region being one of them. Right now, we've been working on to increase the proportion of children under 5 years and pregnant women sleeping under ITNs or LLNs, and also to increase the proportion of the suspected malaria cases receiving early and effective treatment in line with the national treatment policy. The last one was to increase the proportion of pregnant women attending at least 4 ANC visits during pregnancy.
Last year, that is 2010-2011, World Vision had a mass distribution of LLINs project, whereby they distributed 103,000 nets to the whole of West Pokot County. It has also been having the case management project. It also had a communication for change project that is in Teso and Punyala. This is the malaria cube. The malaria cube has just pictures, and you just point to the picture when you are passing the message. Panel number 1, what is malaria? There is a mosquito. You point to the mosquito. Malaria is caused by a female Anopheles mosquito. You point to someone lying down. Malaria causes someone to feel weak and sick and sometimes have headache. You use the most simple language, as simple as possible. This is a coffin. If you don't take prompt action when you have malaria, you can die.
The standard treatment guideline, which we are still using till now, came out in 2007, recommending that pregnant women in the first trimester must be treated with quinine. And in the second and third trimester, the drug of choice for the treatment of uncomplicated malaria is ALU. With these changes, it was still advocated to continue using SP for intermittent preventive treatment. IPT policy was adopted in Tanzania since August 2001, whereby 2 doses of SP are given throughout pregnancy period.
Most of our interventions are and can be done by even the community health workers. Even case management, where the health workers have been doing, even the community health workers can indeed do. It is agreed that even those community health workers can indeed test and treat. So there is no intervention that is geared towards preventing and controlling malaria that cannot be done by the community health workers.
All the activities right now and henceforth we are geared to community strategy. We are rolling everything to the community, and therefore we have to involve the community, active community participation, involvement, so that we achieve whatever we have to achieve.
There's still need for universal coverage. That's something that each and every country that has malaria is targeting, but with less funding. So we are still targeting to cover all households with long-lasting insecticide nets, but we have less funding for the same. Then we need innovation to provide better and efficient malaria control tools. We are saying that we should not stagnate from the same net we are using 5 years ago. Work with the private sector to encourage innovation so that malaria programmers have better IRS products, you have better nets that last longer, and you have an insecticide that lasts longer in the nets. We need to switch to targeted distribution so that we meet those gaps in long-lasting insecticide nets. But the aim must be to sustain the gains. And that was the theme for this year's World Malaria Day.
We know that the existing tools, that is the long-lasting insecticide bed nets, the indoor residual spraying, the rapid diagnostic tests, ACTs, and IPT need to be covered universally, and that's why we are in Kenya. We need to have access to all this intervention. And I think we are lucky now for the Kenyan country that through round 10, we are able to see that we can be able to realize some of these, especially universal coverage, because it is this universal coverage that we can be able to provide effective interventions at each and every doorstep for every human being living in those areas. There are also new initiatives globally. We can see that most of the new initiatives that are there, we are talking about community case management, and which is the bedrock of the current Global Fund Round 10 in Kenya, to make sure that we are able to provide what we call the T's, which is one of the new interventions, the 3 T's: treat, test, and track.
I'm a provincial administrator, chief of an area in Kisii. My names are Mary Kemuntoratemo. To give you the overview of provincial administration in Kisii, provincial administration in our communities, we know that they are the people with people. They are here at grassroots. Our work is to coordinate government activities, to implement government policies, and also to work with our people who are our core people, because without them, we are not having any job to do. Now, Marlene in Kisii partnered with public health. They showed a very good example in that their approach was to work with the people, the community health workers, who they found at the ground.
I'm Peter Nyabwengi from Kisii County. Today I'm here to present community health workers. 3 bodies, Marlene Provincial Administration and MOH, held meetings and selected 500 CHWs plus CHC from all 6 districts. Marlene trained the CHW in cooperation with MOH in February 2010. Trained on community health strategy and the malaria social and the behavior change communication and some other components so that malaria message could be passed to the communities.
I'm Amisi Oyunge. I come from Kisii County, from a group called Amshield International Theatre Foundation, which was started back 2005 by 13 members to 30. Currently, we are 182. We were selected, good to say, by Malin International. We were trained on malaria issues, meaning we usually go with them at field outreaches. We were also trained by Afya Plus, Western Kenya, as Magnet Theatre ambassadors at Kisii County.
Good morning, everyone. My name is Frederick Nyambare. I'm from Beya. With Beya, I work as the partnership manager for Sub-Saharan Africa. Beya Healthcare is a branch that is dealing with pharmaceuticals. They produce drugs. We have material science that produces high-tech materials for making homemade equipments, hospital equipments. And within bio-crop science, we have bio-environmental science, which is specifically designed to manage vector control.
Now, it's common knowledge that some pregnant women act to the side effects or the induced side effects of SP. It appears you seemed to ignore because I did not see whether you are provided for any intervention as you did it to ALU by administering it in trimesters.
In Tanzania, we use SP only for intermittent preventive treatment, not for treatment of malaria. The IPT is supposed to be given on the 20th week, as I said, and the second dose is taken on the 28th to 30th week on SP. And also, I want to clarify that SP is used for intermittent preventive treatment, whereas ALU is given for malaria treatment only in the second and third trimester because it has teratogenic effects. Therefore, in the first trimester, for a woman suffering from uncomplicated malaria, then they are given quinine and not SP. SP has already been withdrawn for malaria treatment in Tanzania.
Every malaria case is tested and treated effectively within 24 hours. So with the community strategy which the ministry has already set up, malaria program has already instituted and they support through the Global Fund, especially in this region, Nyanza and Western, to make sure that community health workers will be able to test and treat at that level. And already there's procurement of rapid diagnostic tests which can be handled by non-laboratory trained technician to be able to tackle that. So already the government has put that effort, and in fact, there's another group which is actually planning in Kisumu Hotel right now how to go to implement that strategy using the community health worker so that every person will have an access to a test and then be given an effective treatment. So the community health workers that we've also seen with the experience that we've had from Kisii is that they'll have the rapid diagnosis at the village level where they'll be testing every fever case. If it is found positive, they'll give it a proper anti-malaria. So that is where the strategy is. As Dr. has said that currently we're talking about 60% coverage of the health facilities. But the program or the National Malaria Program has realized that accessibility is not universal. And that's why they are put to that level of community level where by certain areas, I'm sure that we have lived in Nyanza, there are certain areas that they do not have even a closed health facility. So where we don't have closed health facilities, the community health workers are being trained on how to test and how to give proper treatment after a positive test.
We have the long-lasting insecticide-treated nets. That one has already been provided. And last year, the year 2010-2011 government fiscal year, there was mass distribution of nets. and Nyanza and Western people got these nets, and we are talking of universal coverage. That is one net for every 2 people at risk. And for this distribution exercise, there was a lot of involvement of the people on the ground, the community health workers, the government, the provincial administration, to make sure that at least all the population was covered. The question which we need to be asking ourselves is, what is the utilization like? We have seen previous surveys or evaluation reveal that, yes, the people have the nets, but they are using them for different things. So what is the role of the media in this case? The role of the media will be to educate the public that we have got the nets, yes. Are we using them every night? You know, the way they say every day, every night, is one sleeping under a net. And as opposed to talking of the pregnant women and the children under 5, we are talking of the entire population in this case. Nyanza and Western were told about that area still having a high burden of disease due to malaria. So again, there is concerted effort to make sure that there is social behavior change. And Adman mentioned of Global Fund Round 10, we are focusing on one, integrated community case management of malaria, that is utilizing a community health worker. We are going a step ahead to make sure that there is social behavior change. It is true that the people have the information, but are they changing their behavior? What are their attitudes like? When it comes to care seeking for fever, do they stay at home or do they go to the health facility? And upon which, or even if not at the health facility, to the community health worker, do they get their diagnostics right? So those are some of the things that we are following up on.
I'm Thomas Otieno. I work with Fish FM as a news reporter. I'm here to learn, and then after learning, do a lot of objective reporting on malaria-related issues.
My name is Caleb Kola. I work with Radio NAM Lolwe, and I'm here to get more about how we can fight malaria from East Africa.
I'm Susan Lembe from Kenya News Agency, and I'm here to know more on malaria and report objectively and correctly on the subject.
Media is one of the key partners in the health promotion, especially in public health programs. At most of the time that we work in our health programming, we do not program to work with the media. It comes as an afterthought. What we are saying is that when we go to the community, when we ask them, where do you get the source of information? In most of those project reports that you've seen here, when they are asked about where do they get information about malaria, about the first-line treatment, either it's through the radio or the health workers. One of the research done in Kenya and contained in the malaria communication strategy says that media is the most trusted source of information. Most of the KeNAAM members came together and thought that malaria is not getting enough coverage for the programs that it's doing. So we tried to capture this by training all the media houses, because we focused on the media houses, especially the health writers. And we were able to bring them together to a residential training for 3 days. Also, through the commercial malaria project, we were able to now focus at the community level journalist based in Kisii and its environs. and we were able to train about 24 of them. Basically here we were focusing on the key messaging within the communication strategy and the different messages that should go out.
I think what I've learned is it is also important to integrate malaria programs with other program areas. Like I think Health Right yesterday presented about integrating malaria programs with some of the agricultural products that they do, and it brings more mothers to the facilities to access the long-lasting insecticide nets and also to get treatment for malaria. And it is, I think it is one of the innovative ways that also helps these mothers come to the health facilities.
This particular conference, the KeNAAM Fresh Air Conference, is a very important conference because partners share very useful information. This year's theme was on community activities that are deemed to improve access to malaria interventions. We have many effective malaria interventions in terms of use of nets, prevention of malaria, and the treatment of malaria.
Yeah, this year's conference has been very well planned and well attended, and the participants have engaged fully in the discussions. A lot of new things have come up in the prevention and control of malaria over the years, and this year's focus on leveraging our resources and our energies to control malaria in communities is so relevant. I was particularly thrilled to find out what other partners and participants are doing in endemic and less endemic areas to integrate malaria with other health interventions, and also how they are dealing with periodic transmissions of malaria, particularly in areas where there is no transmission all year round. I was indeed grateful to hear, especially people who are dealing with mobile populations like refugees, and how they are able to manage malaria within populations that are on the move. So I think these are a few that I've learned, and I must say a lot more needs to be done, and I feel energized going back home that I will take these experiences back and be able to help improve the work I'm doing.